Thank you. Thank you very much. And let me add my thanks to Osstell for the invitation and to all of you for getting up at such an early hour to be here. There is a fundamental problem with this whole subject. That fundamental problem is one of definition. What are we looking to do here? What do we mean when we say primary stability? What are we trying to achieve by measuring primary stability? If we can't all agree on these definitions, then basically you're talking about apples and I'm talking about pears, and never the twain shall meet. It's very interesting. You used the word risk. Are we measuring risk? And what do we mean by measuring risk? Or are we just looking to leave the office feeling comfortable because when we hammered the nail into the wall, it was bloody tight? Right? Also, understand something. There is a fundamental difference between a dynamic process and a static process. Primary stability, which we can try and define at some point, is a static process. It is a moment in time, and any unit of measure that you use to record primary stability is therefore, by definition, a static measurement. It cannot be compared or contrasted to subsequent measurements. A dynamic process is one in which change takes place, and you require an objective measure that can follow that change. Just remember those two things, and then appreciate and understand the ignorance and the ridiculous nature of the debate going on in our profession or in this field about so-called primary stability. Now, I'm a great fan of this man. Leonardo da Vinci wasn't only a great artist, he was a great scientist. And this is a quote of da Vinci's that I've been using at the beginning of pretty much every lecture I give, just for the last year or so, because when I read it, I just was bowled over by it, because I think it pertains so much to our field, where he says, although nature commences with reason and ends in experience, it is necessary for us to do the opposite. That is, to commence with experience, and from this to proceed to investigate the reason. And in the area of primary stability, this is so very true. We have experience with implants that goes back 30, 40 years when an Osstell machine never existed. Yeah? And we talk often about the fact that in those early days, they talked about micromotion, micromobility, but it's taken 30, 40 years of experience for us to get to the point where the literature is dominated by this debate. So primary stability appears to be the big issue at the moment. And why is it the big issue? Well, it's only the big issue because it's been driven by a shift in protocol from delayed load to immediate load. Immediate placement, immediate load. Very challenging environment to the biology. And as you will appreciate, peppered throughout this lecture, I will refer to biology. We're not working with this wood here. We're working with a material that responds to trauma, that responds to load, that heals, that injures. And it would behoove us to remember that when we discuss this subject. One can debate if you take a temporary crown, you leave it a little short, maybe you procline it a little bit to keep it clear of functional contacts. Is this just temporization, or is there an element of immediate load? I would argue that any time you place a temporary restoration on an implant, there will be a degree of immediate loading. And if you're placing an implant into a fresh extraction socket And in this case, we've got an apical defect as well. So even if the implant goes beyond that defect, you now have a mid-body defect from the implant's perspective, a mid-body defect where there is an absence of bone-to-implant contact, mechanically speaking, and of course at the crest, where you have the diameter of the socket that is larger than the diameter of the implant. So the implant's deriving its primary stability, whatever that is, from a small amount of bone. Now, I'm going to make a heretic statement, but it's the truth. There has been a myth perpetuated in implant dentistry since Professor Brånemark himself defined the term osseointegration. Osseointegration, as you probably know, is defined by its appearance at the light microscope level, a direct contact between living bone and a load-bearing implant. But we knew since the early 80s, the 1982, 83, 84, around that time, from the group at the Handicap Research Institute in Gothenburg, that when you look to osseointegration under the ultrastructural microscope, you never saw contact between bone and an implant. But we know that, don't we? Titanium is not bioactive. It's bioinert. If titanium were bioactive and bone literally bonded to our implants, why wouldn't we just use a titanium cylinder unthreaded, machined? And it would work. But it doesn't. How much torque do you need to remove an original machined Brånemark titanium implant? 65, 75 Newton centimeters. It's nothing. One could almost argue, God forfend, that the original Brånemark implants were put in with mechanical stability in dense mandibular bone, which has, of course, a low metabolic turnover, and they remained only mechanically stable, that they did not osseointegrate, whatever osseointegration is. The point, my friends, is this. Osseointegration is micromechanical fixation by remodeling of the bone. There is no contact between bone and the surface of any implant on the market today. Yes, there are some implants that suggest they have enhanced their surface energy or their bioactivity even. But until we get a truly bioactive surface, you don't get bonding between bone and surface. So we are talking about a dynamic process that goes from macro-mechanical stability to micro-mechanical stability. And the important point here then is, how do you measure the change? Or do you measure the change at all? So let's go back a step, and I'll come back to that. I just wanted to throw that out there as a... It didn't look like it shocked you, but I mean, it shocks me every time I say it. But let's go back and understand what primary stability is, as far as I can tell, in terms of what most people define it today. If I ask most people how they define primary stability today, they all say the same thing: high insertion torque. And how do you influence that, I ask? Well, most people will come up with the same answers. Implant geometry, maybe the thread profile, maybe the surface preparation. Bone density. Dense bone gives high primary stability. Surgical protocol, use of osteotomes was mentioned, for example. And certainly, you know, it's fair to say that there is very little available to measure primary stability. We have our own subjective evaluation. Peak insertion torque, maybe the Perrier test, and of course resonance frequency. We shouldn't shove aside subjective evaluation. The human brain actually is remarkably good at subjective evaluation. If I give you a heavy picture and I say to you, stick a nail in the wall and hang the picture on the nail for me. You will have a degree of intrinsic knowledge just from the way you hammer that nail into the wall and how it feels, combined with the weight of the picture. You will have an intrinsic sense of whether that nail is capable of withstanding the weight of that picture. But here's the problem. In our world of dentistry, we can't measure the weight of the picture. In our world, the weight of the picture is the functional loading, is the occlusion, and we cannot measure that. So what sense then the purpose of measuring how tight the nail is in the wall? We need a dynamic process that will allow us to appreciate changes in the, if you like, tightness of the nail before and compared to after we hang the picture on the nail to see if the nail is becoming loose. And so this has been an eternal problem so far. We can talk about the importance of macrothreads, microthreads, tapers, cylinders. I mean, you know, of course, the biggest problem in implant dentistry is there are too many variables. Every consensus conference, save perhaps ironically for the sinus consensus conference in '96, almost every consensus conference tells us the same thing over and over. Too much heterogeneity in the literature, not possible to come up with conclusions. And that is probably the biggest problem in this debate. You know, it's no point comparing one study to another about peak insertion torques or bone density or ISQs, because they're using different implant systems, different surgeons with different preparation protocols, different patients with different bone densities and different bone physiologies. So I like to bring everything back to basics, fundamentals. So let's bring the mechanics back to basics and fundamentals. Every implant company in the world should be teaching us this equation. They should be selling their implants based on this equation. Everyone has a favorite implant system, so it doesn't matter. Just let's focus on one implant system. Whatever the system is you use, focus on it. And let me ask you a question. Does that implant system have more than one diameter of implant? If the answer is yes, then let me ask you this. Does the implant manufacturer recommend a different insertion torque for each different diameter of implant? The answer for most will surely be no. Yet we understand from this very sort of fundamental and basic equation that the critical pressure in the bone, for want of a better description, how much you crush it, how much strain you put into that bone, which is characterized by the red letter P here, is directly proportional to the height of the implant, two constants, mu is the coefficient of friction, and pi, which of course is a must-have in every mathematical equation. I'm no mathematician. But look at this. D squared, d to the power of 2, is proportional to the diameter to the power of 2. So you can understand if you use the same insertion torque for a 3 millimeter implant or a 6 millimeter implant, the critical pressure will have to reduce by a factor of 4 if you're doubling the diameter. So by that understanding, we should be using wide diameter implants everywhere. And of course, the profession went through that process of using wide diameter implants. So why aren't we? Well, of course, one of the other problems is it's not quite that simple, because in order to place a wide diameter implant, what do you have to do? You have to have a big hole. And if you have a big hole, what do you do to the bone around that implant? You thin it out. And I say again, cortical bone has a very low metabolic turnover. There is a critical thickness or perhaps thinness at which cortical bone is no longer viable, and it resorbs. So all these things are going on in my mind. All these things are going on in my mind. There are so many studies, it's almost exhausting, and you'll be pleased to know I'm not going to list them all, looking at the correlation or the absence of correlation between peak insertion torque, ISQ. And it infuriates me. Why? Because peak insertion torque is a static measurement, a moment in time, never to be repeated, never to be recorded again. It's impossible. ISQ is supposed to be a dynamic process where you compare one measurement to another. So how can you possibly have the ability to talk about correlating a one-off static measurement to a dynamic measurement? It makes no sense. And what about predictability of risk that Professor Wagner mentioned, an ability to measure risk? Most studies show a complete lack of correlation. You can insert an implant with 30 Newton centimeters and you can get a very high ISQ. You could insert it with 100 Newton centimeters and get the same ISQ. So of course it's inevitable. Everyone says, well, what the hell is going on? What are we measuring here? Well, for a start, there's a fundamental problem. You're measuring two different things. One is measuring rotational friction. One is measuring stiffness, lateral stiffness. I call it axial stiffness. They get a bit upset by that because it's not measuring stiffness this way, it's measuring stiffness this way. They're different things. The question is, what's more important? Anyone in this room, and I'm not asking for a show of hands, just think about it. Anyone in this room ever experienced a so-called spinner? An implant that has no or very little insertion torque. Is that predictive of failure? Do you automatically remove that implant because you know it's going to fail? Or do you leave it because you know if you leave it, a dynamic process will take place that causes that implant to achieve osseointegration, micro-mechanical fixation? You leave it. Of course you do. Spinners don't fail. You can have a debate about whether you should load it immediately or not, but spinners don't fail. They integrate. If you understand the dynamic biological process that's going on. That's why I looked to find an alternative method for assessing risk, not to find something that just made me feel good when I walked out the door. And I understand that although we are clinicians and not carpenters, I do understand the comfort that we derive from feeling that our implant is tight in bone. I equally understand the slight flutter, the butterflies, when an implant's not tight in bone, especially if you're going to immediately temporize it or immediately load it. So we have to learn from our experience and from that deduce the reasons. Well, we understand what RFA is. It's effectively a change in the resonance of the implant as the interface becomes stiffer. What do we mean by that? We mean a reduction in the intrinsic micromobility of the implant. And at this point, I want to emphasize a fundamental difference between micromobility and micromotion. That has intrinsic micromobility. We don't know what it is. Maybe we can measure it. That is micromobility. You can't see it. You can't feel it, but it's there. And it's dependent on the stiffness of the interface, but it's also dependent on the stiffness of the material that surrounds it. This is micromotion. The effect of an external force applied to it allows us to measure micromotion. Subtle, but very important in their difference. RFA does not apply a load. It is measuring micromobility, not micromotion. Okay? Okay, so what does insertion torque measure then? Well, insertion torque measures resistance to shear. Now, there is value in that only insofar as bone responds least favorably to shear. It responds very well to compression, slightly less well to tension, and worse to shear. So we understand the importance of having a resistance to shear, particularly if you have a non-threaded cylinder implant. Yeah? Why do we have threads? And why do we classically, historically see bone stop at the first thread? One of the possible reasons that's postulated is because that's the first point at which we convert shear stress to compressive stress. Because as soon as you do that, you change stresses in this way to stresses under the flange of the thread. So it becomes compressive. So rotational resistance may have some philosophical importance. But how many of our implants are loaded to rotation? I don't think many of them, to my knowledge. Patients' jaws don't go round in circles. There may be a vectorial component, a small vectorial component, particularly to a large spade crown, like an anterior incisor, possibly. But as a general rule, we're not interested, functionally speaking, in rotational forces. You're all familiar with a resonance frequency graph. I call this the heartbeat of an implant. And they all look like this, or at least up until recently, they all look like this. And the dip you see is the loss of primary stability. How do you measure the loss of primary stability with insertion torque? Well, of course you can't, because it's a static measure. You could try doing a reverse torque. Hands up, who wants to do a reverse torque at 3 weeks on their implant? I don't think so. So what is the loss of primary stability? It's two things. First of all, you have to understand bone is a viscoelastic or semi-viscoelastic material. If you crush it, as in an osteotome technique, the trabeculae will stress release within the bone. It's much harder for lamellar bone. The way lamellar bone stress releases is to resorb. Yeah? But there is an intrinsic viscoelastic property to bone. So when Ulrike talks about loss of ISQ from a high level to a level still above 70, effectively she's measured viscoelastic stress release within the bone directly adjacent to the implant. That's my interpretation. May be wrong. You can criticize. It's just my interpretation. And of course, around the implant, you have a web. It's a three-dimensional phenomenon. It's not a one-dimensional phenomenon. And that just compounds and confounds the whole problem. Because as we all know, most of the time we put our implants in, maybe there's a little buccal dehiscence, for example. What impact does that have? Maybe there's an apical fenestration, like I showed in that first clinical slide. What impact does that have? These all confound the problem. Bone density, we've understood that, at least in our minds, that dense bone will yield a higher primary stability than soft bone. But actually, most of the literature shows that there is a dubious correlation. Why? Because it's also dependent on the way you prepare the bone and the geometry and thread profile of the implant. Too many variables make it impossible for us to really get a grasp on the problem. But you can see here, Dejidi is a good friend, and this is a very significant number of implants. Demonstrated that he felt there was a statistically relevant dependency between insertion torque and bone density, as did Reva Barrowell and my good friend Clark Stanford. But here's the thing. when I look into the literature, I found that you could find any study, you could pick it out. So for example, this is from a couple of studies by the same group, but in different journals, and I've just sort of mashed it together. And what they were showing was that, you could have bone density measured in Hounsfield's as low as 36 up to as much as 800, and the range of insertion torque values was very, very small. And more importantly, they had similar ISQs. Different studies, different results, same group. So what are we to believe? Oh, sorry. Al Nawas published a study in 2006 where he talked about the ability for peak insertion torque to be a predictor for failure as wholly unreliable. I'm sitting on the plane coming here, reading the latest issue of Clinical Implant Dentistry and Related Research, and the first article's by Al Nawas's group, and now he's telling me that ISQ is wholly unreliable as a predictor for failure. Which is it? I don't know what I need to go back and look at the original study to see if he's using the same products, the same surgical protocols, etc., etc. But within 6 years, he's gone from telling us that PIT is useless and ISQ is a good predictor for failure to 2013 telling us the exact opposite. Because, my friends, literature is a little bit like osseointegration. It's a dynamic process. And the problem is most people stand on a platform and treat it as if it's a static process. And I'm not here wanting to pull the wool over your eyes and show you some choice studies that I've pulled out to prove my point. I want to be honest and open with you and say that there is a problem with the literature. Osteotomes. I've got a real thing about osteotomes. I mean, everyone uses them to increase primary stability. And certainly, there are a lot of studies that suggest that it does. But equally, there are a lot of studies that suggest it doesn't. In this study by Kraft, not a particularly illustrious journal, I have to say, but in this study, he couldn't demonstrate any correlation between the use of osteotomes and stability measured by RFA. You see, the thing is, RFA isn't really measuring what everyone's looking for it to measure. Why? Because they're using it as a static instrument, like insertion torque. And it's not a static instrument and shouldn't be used in that way. Although it's very tempting. When I'm doing immediate load, immediate extraction and insertion, of course I take an RFA, and of course I want to see a figure of 60, 70, 80 make me feel good, right? But it's meaningless. I'm just doing the same thing that all my pit people do. Walk out the door, lock the door, and feel good about it. But it's meaningless. It isn't really assessing risk. It's just telling me something about a mechanical moment in time, not a biological dynamic period of time, which is what it was developed for. And so it goes on. I choose this study because in this study, they actually used a commercial implant and an equivalent of the commercial implant that they had made by the company as an experimental implant, where it had a bulge so that it would apply much more insertion torque. And interestingly, what they found was that there was significantly more bone loss with higher insertion torque. Which brings me to my next little point. Insertion torque potentially kills bone. Critical pressure P, the little red P, is crucial to us as clinicians. If you ignore P, you ignore the fact that you're not actually interested in how the patient leaves your practice the day you put the implant in. You're more interested in how that implant looks in that patient a year from today. 5 years from today, 25 years from today. And if that's not your attitude, then I don't know why you'd be at an illustrious meeting like the EAO. Because if you take the static, once-only approach to implant dentistry, stack 'em, rack 'em, and screw 'em in tight, yes, you'll feel good when you go home, but down the line, you'll start to see this sort of thing. I dabbled with osteotomes for a very short time, and particularly in lower density bone with very thin cortical bone, I myself experienced problems with marginal bone loss. So I'm very concerned about that. Now, Ulrika introduced this graph. I don't need to focus on it too much. It's really to just constantly re-emphasize to you that this is a dynamic process, and to understand that we lose mechanical stability within 3 weeks and then we depend on something else. And only ISQ allows us to measure that change. You cannot go back and repeat your peak insertion torque. It's not giving you anything diagnostic. A spinner will integrate. There is no diagnostic value in insertion torque. All it does is make you feel good, but at the same time, it may irreparably damage the cortical bone. Remember, remodeling leads to loss of primary stability. So I've tried to repeat those graphs with my very poor hand-drawn curves. Let us imagine you insert an implant with 25 Newton centimeters and you get an ISQ of, say, 70. Perfectly reasonable. And you get a remodeling process, which we know takes place around 3 weeks. What happens then if you say, no, I want to feel good about myself, so I'm going to actually increase the insertion torque to 75 Newton centimeters? You still get the same ISQ. Many, many studies show that. The question is, what happens to biological stability? Well, I think it's pretty clear from the literature, certainly from the histology. You delay healing. You get a much more significant resorptive process. You delay the onset of secondary biological stability. By how much, we don't know. We need to do more work on this. I'm in the business of secondary stability. I want my implant to osseointegrate in the fastest possible time. So it won't surprise you then to know that this whole process started when I realized that, contrary to convention, as it seems to be at the moment in the profession, I recognized that most of my single-tooth immediate implants with immediate temporization were being placed with a very low insertion torque. My target insertion torque has always been 25 Newton centimeters, but I knew that I had a number of implants with much less, 20, 15, 10 Newton centimeters. These are finger tight. But I also knew that I had a high success rate or survival rate, 96%, conventional survival rates. Then I looked into the literature, and I found equivalency in the literature. I think I've got a couple of quotes, but let me just say this. We know when we look at ISQ comparing immediate load to delayed load that often there is no difference. There's often no difference. In fact, today, with new surface technology, we can almost obliterate the dip. Why? Because secondary biological stability is now so much more rapid with these new surfaces that it masks the loss of mechanical stability. Bischoff couldn't show any difference between stability between immediate and delayed load implants. By contrast, you look at some implants on the market that are specifically designed and geared towards maximizing insertion torque. There's not a lot of literature in them. This is one particular study I found, very recent. You see, it's only this year. Insertion torque was significantly greater for these implants compared to standard matched Brånemark implants. But within this sample population, the survival rates were lower, and there were no observable differences in RFA value. So you're damaging the bone, but you're gaining nothing in terms of lateral micro-stability, lateral micro-mobility, the thing that really matters. You're gaining a lot of rotational resistance, big deal. Spinners integrate. And Tolyanik astounded himself because this was an immediate load study in edentulous maxilla of all things, where they had a target insertion torque of 40 Newton centimeters, but they did not exclude implants with less than. And when they looked back at their data, they were shocked to find that nearly 40% of implants had an insertion torque of less than or equal to 20 Newton centimeters, and 12% had less than or equal to 10 Newton centimeters, and it made absolutely no difference to the outcome. 96% success. And they comment in their own discussion and conclusions that whilst primary stability plays a role, and so by definition what they mean when they say that is insertion torque. So they're saying that while insertion torque likely plays a role in achieving successful outcomes, perhaps other factors may be acting. Otherwise, how did we get this result? Answer is because when you splint an implant that has no rotational resistance, guess what? It can't rotate anymore. Right? And so on and so on and so on. I don't want to labour the point, but there is lots of data to show that you can get high survival rates with implants placed with low insertion torque. This study is a very important study, perhaps the most important. Paolo Trisi is a good friend. I know that he believed passionately as me that high insertion torque was a no-no. So he set out to prove it. And in so doing, he disproved it. He believes, in his interpretation of his own work, that this study demonstrates that high insertion torque is okay. Why? Because effectively in the study, he showed that with high insertion torque, you didn't get failure of the implants, you got a higher initial ISQ, you got a higher initial bone implant contact, and that at the end of the study, it was no worse than the implants placed with a low ISQ, or a low insertion torque rather. However, let's look at it in a bit more detail, because one of the things he commented on was that with the high insertion torque, he routinely saw microfractures histologically within the cortical bone. Now, he's very careful about his terminology. He says there was no evidence of necrosis. Well, that's true. There was no evidence of necrosis, right? But these are the pictures from the study. There was massive resorption. This is not necrosis. This is resorption and remodeling. Different thing, yeah? Here's the microfractures from the high insertion torque. You get this almost liquefaction of the bone. I'm being a bit provocative by using that term. And you get resorption. Who knows how sustainable this woven bone callus is? Who recognizes this defect, right? This is what you see on radiograph when you don't have the benefit of histology, yeah? The interesting thing about this study was that in the low insertion torque group, there is a massive gap in the cortical compartment. There is no bone contact at all. So anything that occurs as a result of dynamic biological bone apposition, distance osteogenesis or contact osteogenesis. And the bone you see now in this gap is not resorption. They look similar, but this isn't resorption taking place. This is bone apposition taking place. Biologically, the direct opposite phenomenon. And yet, when we look at ISQ, we see a very interesting thing. We see what Ulrika saw. In the higher insertion torque group, we see a almost straight line drop. Not very hard, not very much of a drop, I grant you, but a drop. What we're measuring with that drop is not the failing of the implant. As you said, it's not failing. What we're measuring here is a loss of stiffness due to, number one, the viscoelastic, intrinsic viscoelastic properties of bone, and number two, the resorption. Peak removal torque is an interesting thing. You're not going to use it clinically, of course. But look at this massive drop here. Absolutely huge drop within the first 2 weeks before it picks up again. So effectively, what's happening is that the high insertion torque group are traumatizing, they're injuring the bone, you're getting a massive resorptive response before the body can repair it. Whereas with low insertion torque, you get a gradual increase where you haven't traumatized the bone. Now, my point is simple. If the ISQ is the same between an implant inserted with 20 Newton centimeters or even 10 Newton centimeters and an implant inserted with 100 Newton centimeters, would you rather get an ISQ of 70 by damaging the bone? Or would you rather get an ISQ of 70 by respecting the bone? I know which side of the fence I fall on. And so finally we come to micromotion and micromobility. It's the only thing that matters. Implants are subject to micromotion, that is the potential disruption of the interface by application of an external force. We call that functional occlusion. That is the only thing that matters, not rotational resistance measured by peak insertion torque. Treacy, Smuckler-Moncler, and now, more recently, Pagliani have clearly demonstrated there is a direct correlation between RFA, it's an inverse correlation, between RFA and micromotion. Okay? In other words, the less the micromotion, the higher the ISQ. And if you use ISQ in the way it's meant to be used as a dynamic measuring tool, then you should hope to see, at the very least, no loss of stiffness, and at the very best, an increase in stiffness. So if we look at this graphically, and my thanks to Osstell for these graphs, what we discover is that when we look at a graph of micromobility, for very high micromobility, this is the intrinsic movement now of the implant, for very high micromobility, small changes in ISQ from, say, 50 to 55 represent a massive decrease in movement, or to put it another way, a significant increase in stiffness. Even between 50 and 70 ISQ, we still, as the curve plateaus, we still see an almost 50% reduction in micromobility, or a 50% increase in stiffness. Looking at it without the scatter plot dots, this is how the curve kind of looks. And you can understand now that once you get to an ISQ of, say, 70, changes in ISQ make relatively small incremental changes in stiffness. So the key is definitely about the sensitivity of the instrument. That's the important thing. And this perhaps shows it better than all of them, because this is a very, very highly inversely related curve. Young's modulus, that's stiffness versus micromotion, yeah? If the Young's modulus starts from a high level, somewhere here, you can see that the stability will not increase in a significant way. In other words, if you start with an ISQ of 70, you expect it to stay at 70. But if an ISQ starts at 45 or 50, that's where you're measuring risk. That's where the dynamic process comes in. Because now you're starting somewhere here on the curve and you want to see if you get round the bend. I'm nearly finished, guys. There have been many recommendations then about thresholds. Barrawell, in her study, recommended a minimum threshold of 20 Newton centimeters and an ISQ of 70. Ulrika, reading between the lines, is also offering a threshold ISQ of 70. Nadir was a bit more risque. He said for delayed loading, you could have an ISQ as low as 47. I think that is a bit risky. The problem is, when's he measuring it, right? Maybe he's measuring it at insertion. What he hasn't told you is what does it measure at exposure, at baseline of loading. If it was 47 at insertion and 70 at exposure, then Nadir is right. So you have to look at that. In a study, in that Al-Nawas study that I read on the flight over, they said ISQ was irrelevant, but they were quoting the ISQ at implant insertion, not at time of loading. So they were treating ISQ like peak insertion torque as a single static measurement. It's the wrong approach. This is the recommendations from the company, and we can debate this at length. It's going to take time to really evaluate threshold values, I think. For myself, I know this. I wrote an editorial in Jomi the other month, and I decided that I'm sick and tired of the term primary stability, because primary stability is a carpenter's term used by clinicians to convert what should be a biological, scientifically driven healthcare procedure and converting it into hammering a nail in a wall and hanging a picture on it. So I coined this new phrase, viable constraint. What do I mean about that? Viable is the viability of the bone, and constraint is stiffness. And it's determined by all the things that we've discussed this morning. And I don't know, but I come up with this recommendation. For me, I think viable constraint can arbitrarily and anecdotally be set at a peak insertion torque of 25 Newton centimeters, which by today's standards is pretty low, and an ISQ of 60, or if you're a little bit more nervous than me, maybe 70. The one thing I do think is that they are somewhat interchangeable. If you can't bring yourself to drop peak insertion torque as a value, as a guide to primary stability, then you should know that you can trade them. And I believe this. So if you have an insertion torque of only 15 Newton centimeters, yet you measure the ISQ and it measures 70, you can still go ahead and immediately load that implant. By contrast, if you have an ISQ of only 45 or 50, but you inserted it with an insertion torque of 50 or 60 Newton centimeters, probably chances are you're going to feel comfortable to load that too. Take the carpenter's approach and max up the insertion torque for peace of mind is one option. Behave like clinicians is another option. The problem is that for some, there is no difference. Well, I hope I've kind of demystified a bit, but just want you to leave here understanding that primary stability is not insertion torque. We are not carpenters. Please think like clinicians. Thank you.